Hi everyone, I'm Greg Ceely. I head up the Health Index and Projections team at the Office for National Statistics. It's a bit of a tough act to follow that last one when we just heard that they're waiting on some ONS data. There you go. So I'm here today to talk to you about the Health Index and give a very quick overview of why we've made it, how we've made it, what we're doing with it, and what we hope to do next with it, and what we hope you do next with it too. So the idea for a health index came from Dame Sally Davies, the chief medical officer before it was cool. In 2020, of course, the pandemic made Chris Whitty and the CMO a household name. Sadly, Dame Sally didn't get quite the same level of attention, but in her 2018 annual report, she proposed that we should have a composite index that measures health and allows us to track it over time. And that this should capture not just health outcomes, but the wider determinants of health as well. Where we have, as a nation, measures such as GDP, they allow us to measure progress nationally in a financial way, but we don't quite achieve the same thing with health measures. There are plenty of existing metrics and tools such as OHID's fingertips and outcomes frameworks, which do provide information on health, but either don't summarize it into a way where the media really picks up on it and can get these stories to the public and get that attention to them. Or aren't trackable over time, such as the index of multiple deprivation and its health deprivation. So what we're aiming to do with the health index is meet a few different groups of users. One is, on the surface, have a very simple health measure, which people can track over time, which the media can pick up and report on. And thankfully, so far it has to some extent. I'll get onto that later. But also have the detail within it to drill down into different topics and capture these multifaceted elements of health as Dame Sally wanted. So not just health outcomes, but the wider determinants as well. Ideally, because we have this health framework, it would also allow us to influence policymakers and the implementation and interventions that people could make to target certain aspects of health where a certain area is failing. And why ONS? There are plenty of organisations who could produce something like this. After Dame Sally proposed it, a governance group was set up between the Department of Health and Social Care, ONS, and the Cabinet Office, and it was agreed that ONS was the best place to take this forward, partly because of a known impartiality and independence which the ONS offers, but also ONS has an overall mission of producing statistics for the public good, and this fell clearly within that. So, in order to produce a statistic with health in the name and to get this as something accepted, we needed to latch on to existing accepted definitions of health because there are so many different ways people can interpret the term that no matter what we do, someone is going to be upset, but the more we can latch on to something established, the more likely it is that we will become accepted as well. And along those lines, there are a few different definitions that work quite well for us. The World Health Organization is a particularly good one where, and sadly I need to refer to notes, they are after health as a complete state of physical and mental well-being and not merely the absence of infirmity. And that very much embodies Dame Sally's vision of not just capturing health outcomes, but also the wider determinants. There are also models such as the Dahlgren and Whitehead rainbow model, which show different levels of determinants that impact your health. And that's what we're aiming to achieve with the health index, divided into three domains of healthy people, which are your health outcomes, healthy lives, which are your individual circumstances, and healthy places, which are your societal or environmental level drivers of health. Also, we know that lots of different organizations will have different opinions on what counts as health, even within a definition such as WHO's. So we didn't develop this in a vacuum. We knew it would only be successful and effective if we consulted a wide variety of experts. So we worked with an expert advisory group of over 30 organizations representing central government, local government, arm's length bodies, think tanks such as Health Foundation, King's College, and academics, in order to make sure that what we were doing here with the Health Index was as meaningful as possible. And after that, at the end of 2020, we first published our proof of concept release and ran a public consultation too, to make sure it wasn't just experts, but if we wanted to engage the public and the media on this, they had an opportunity to be in as well. So now we had these experts and we had an idea of what we thought the scope should be. what do we do next? Thankfully, the Competence Centre for Composite Indicators and Scoreboards, or thankfully COIN for short, publish a 10-step guide for reducing composite indices, and they are part of OECD. So what we've done to produce the health index broadly follows that. And there is a ton of information on our methodologies online already, so I won't go into too much of it here because I know we're short on time, but there are a few key things that I really wanted to get across. One is we started with a comprehensive review of the data landscape. We were helped by the fact that ONS has tools such as its health and care data landscape database, which allows us to see lots of official statistics on different topics. But we were also able to look beyond official statistics and at tools such as some of the ones I mentioned, like IMD, the NHS outcomes framework, to see where we had topics we wanted to measure within health, what were those existing tools doing. Not everything used by other tools was suitable for us as well. We had to be very critical of what a health index wants to show. This meant that the decisions we made included, if a data source didn't have a clear direction of change, where if something goes up, it means health is improving or declining, it's not really suitable for our purposes. And similarly, if we wanted our tool to be independent, we needed to be measuring health rather than health services where we could. And this meant, as an example, if we wanted to measure something to do with cancer screening, if we measured cancer screening activity, that could be measuring a health service that could change in the absence of actual health changing. But if we measure something like cancer screening attendance, then we're measuring more of an individual level behavior, and that tells us more about people's attitudes towards health and is more relevant to what we are doing. After all this, we had a theoretical structure of what the health index could look like within those three domains I mentioned of people, lives, and places. And we put this together into a hierarchy with subdomains beneath them or specific themes within health, and then the indicators we thought were suitable. And ran this past our EAG, who were able to tell us what they felt was there and shouldn't be, and vice versa, what we were missing, and we could fill in some of those data gaps and remove things which didn't quite fit their definitions of health. After this, of course, there was a ton of data processing. We had to make sure that when it came to our data, any missing values, of which there would be plenty, were imputed, and all of the information about how we did that is online. But we also had to make sure our data were normally distributed, because our main statistical technique for approaching these data was factor analysis. What factor analysis does is observe the latent vectors within a data set, and then look at each of your variables, in our cases our indicators, and tell you to what extent those variables explain the variance within these latent factors. And for us, this meant that it groups our indicators into ones which appear to be measuring similar concepts, and therefore that provides us with our themes or subdomains within each of our three domains. This didn't always match up with our theoretical hierarchy that I mentioned earlier, as you'd expect. So the benefit of using factor analysis was it is, to an extent, subjective. It meant that if something wasn't the perfect grouping for our indicators, but was thematically meaningful to users, we were able to test alternatives to the solution it presented to be able to check that any part of the health index as we present it to users is thematically meaningful as far as what's grouped together and statistically meaningful. And finally, the main thing to mention from there is we've used time indexed standardization. So the health index is based around every single indicator, subdomain, domain, and the top level score has a score of 100 for the health of England in 2015. 2015 wasn't a particularly exciting year for health. This is purely based on data availability. But after that, any score higher than 100, or when you're comparing any two scores, the highest score in the health index always represents better health. The lowest score always worse health. And especially when you're looking at indicator level, there is a level of statistical significance built into this, because a difference of plus or minus 10 in any individual indicator represents one standard deviation of difference between scores. So 110 is one standard deviation better than in 2015. So I'm very much looking forward to the day that the health index is established enough that I don't need to spend the majority of my presentation telling you about how it's put together and encouraging you to believe that it's a meaningful stat and can talk more about the results themselves. Plenty is online. We've most recently published our 2021 data, and more on that in a sec, last month. And the three main ways of accessing this are, in the center, you can see we have a heat map of what's in the whole index and our 50 odd indicators, 14 subdomains, 3 domains, and the top level index score at the top. That's straight from our National Insights bulletin on the ONS website, which is a more typical ONS publication. On the left, we have our interactive tool, which allows you to look at local insights. You can put in your local authority of choice, and it will automatically generate the stories that are most relevant for you across our data set, across all levels of the health index, and drill down into some of this. And then more classically, we have Excel workbooks with all of the data for the health index, including the underlying data before its construction health index scores at each of our geographies, which are lower tier local authority at lowest, all the way up to England. But even though it doesn't quite use the administrative geography, we've also been producing results at ICS level to gain insights into the different health landscapes in ICSs. What do people think? They seem to like it. Obviously, I've cherry-picked nice things to put on this slide, so I will say more in a moment. But we had some very clear aims with the health index, and I think that we have had some level of positive feedback on pretty much all of our overall aims. There are people who have praised its simplicity in accessing health statistics. The media has picked up on statistics in the way that we had hoped. Even the Daily Mail's coverage of our 2021 release wasn't that inaccurate. And people have said it's identified new issues to explore in identifying interventions. They've praised its independence, and it has given more attention to wider determinants of health in local conversations. However, as I've said, this is local conversations. Our main use groups right now are local authorities and directors of public health. And we want to change that. We are perfectly happy with them using it, but we would love if more people used it. We want the public to be able to think about looking at health in their local area, and we want central government to be thinking, how can we use the health index framework to see the impacts of an intervention and see how that looks different over time? Because with the framework we have and the number of different determinants of health we have, it could really improve the consistency of health impact calculations in policy appraisal. So what are we doing next? There are a few different areas where people have very much asked for improvements in the health index. All of the presentations we've seen so far have more granular geographical data than what I've been discussing today. We go down to lower tier local authority, and especially when we're in Birmingham, this is a particular bugbear because Birmingham is a huge local authority and it is not homogenous. So you cannot really identify inequalities within Birmingham at our current geographical level. And this is true of many areas as well. Birmingham just happens to be a very prominent example. So looking at a more granular health index is definitely one of our priorities. Northumbria Healthcare Foundation Trust have piloted producing an LSOA level health index for their area and published that as a proof of concept, which has received good feedback, including from us in ONS. And there are some other local authorities and NHS trusts who are looking to emulate their model. But there's still a long way to go before we have a national coverage LSOA level health index. The other two areas that people really want to know more about are a UK level index. It was mentioned in our questions at the end of the last presentation that understanding Scotland would be really useful. And of course, we work quite closely with Wales in ONS, and there is plenty that we can understand. We understand better if we can look across the UK rather than just at England, as we currently are. And finally, more timely results. 2021 came out a month ago, and this is probably to be expected when we're using 50 odd mostly publicly available sources and have to wait until they are published. But there are still things we can do to look at improving timeliness, such as provisional results when some of the indicators are available, imputing more, that sort of thing. Finally, after those big three, there are a couple of other developments we can still make. We've had really useful discussions with the Alan Turing Institute, with Professor Sir Michael Marmot. I think I've got his title the right way around there, I always forget. And the Office for Stats Regulation to discuss respectively how we can improve our, cool, I'll finish this sentence, how we can improve the stress testing of our methodology choices, the stress testing of our indicator choices, and stress testing of our uncertainty measurement, respectively. And that is me. Thank you for listening.
Thank you.